name is John Martino, and I'm an orthopedic surgeon here at Carillion Clinic in Roanoke, Virginia. I specialize in adult reconstruction, which is advanced hip and knee replacement. Here at Carillion Clinic, we train 2 fellows per year in adult reconstruction and also train 4 residents per year in orthopedic surgery. For some background about me, I went to medical school at the University of Florida in Gainesville, Florida. I then did a year of general surgery internship at UC Davis in California before completing 5 years of orthopedic residency at the University of Missouri Columbia in Columbia, Missouri. I then did my fellowship in adult reconstruction here at Carillion Clinic in 2017 and 2018 before entering private practice in Northeast Tennessee for 2 years. I returned to Carillion Clinic in 2020 as both an instructor and a surgeon, and now specialize in hip and knee replacement. This video is an introduction to knee replacement. This video is designed to express the risks of surgery, benefits of surgery, and describe the nuts and bolts of the operation. After you watch this video, there will be 3 options. For some people, they will watch this video and have no further questions and will not need to see me back in clinic until you have the actual surgery. You will have several appointments with my PA and our team in order to make sure everything is lined up for the surgery, but you will not need to see me for the surgery discussion if this video answers all your questions. The second option would be that you have questions after watching this video, and we could schedule a phone call called a telemedicine visit where I could answer those questions for you. The third option would be that you watch the video and have questions that you would like to discuss in person. We could then schedule an appointment in the office for you and I to answer your questions. Just be aware that with either a telemedicine visit or an in-person visit, you may have an additional co-payment or charge for the office visit. This video is designed to help decrease the number of visits you have to come to, but also decrease the amount you are paying for co-pays. However, I still want to make sure that you hear all the information that I normally tell patients and are able to ask questions if needed. I always like to explain to my patients what arthritis actually is. Many people think that arthritis grows in a joint, but that's not actually what happens. Arthritis is actually a physical loss of material. The analogy to a car for arthritis would be wearing down the tread on the car tires. And before you see an x-ray of a normal knee on the left-hand side of the screen and an arthritic knee on the right-hand side of the screen. When you look at these x-rays, we're looking at the knee joint from the front, and this is a left knee. This right here is the femur, which is the thigh bone. This bone right here is the tibia, which is the shin bone. The small bone on the outside is the fibula. And then the kneecap or patella is right here on the front of the thigh bone. The space in between the 2 bones that I'm tracing with my pen right now is the joint. That's where the bending and straightening occurs. Between the end of the thigh bone and the top of the shin bone, you should have a gap or a clear space on the x-ray. That gap or clear space is full of 2 soft tissues. One is the cartilage and the other is a meniscus. So you have cartilage and a meniscus here, cartilage and a meniscus here. These 2 humps in the middle are attachment points for what are called your ACL and your PCL, which are the 2 main ligaments inside the knee that help with knee function. As you lose the cartilage and the meniscus, you lose the normal joint space between the 2 bones, and that is what we call arthritis. So arthritis, by definition, is a loss of articular cartilage, or the padding between the 2 bones. And therefore, the analogy of your car tire where you wear down the tread is apt, because as you wear down the tread on your car tire, that's a bad thing. And as you wear down the cartilage in your knee, that is also a bad thing, and we call that arthritis. This patient has normal thickness of cartilage spacing between the 2 bones, and is fairly equal from the inside of the knee to the outside of the knee. In contrast, we can see the patient that has arthritis on the right-hand side of the screen. Once again, this is their femur or thigh bone. Here's their tibia or their shin bone, their fibula, and then the kneecap is right here. The first thing we can notice is that this patient no longer has a straight knee. So their thigh bone comes down, but then the angle changes, and this person is bow-legged, or what we call varus deformity, purely from their arthritis. Here on the outside part of the knee, the gap between those two bones is actually bigger than it should be because of the change in alignment of their leg. The ligament on the outside part of the knee is getting stretched out. Here on the inside part of the knee between the thigh bone and shin bone, they have no space left between those two bones, and that is what we call bone-on-bone osteoarthritis. And this patient is certainly a candidate for a knee replacement after they have failed conservative treatment. This is a diagram on the left and an x-ray of a knee replacement on the right. As you will see when I show the model, a knee replacement consists of multiple metal and plastic parts. This is the thigh bone here with the metal part or the metal cap that goes on the end of the thigh bone. There's the piece of plastic that is the replacement for the cartilage, that is the bearing in the knee joint. And then on top of the shin bone, there's another metal part that has a small extension called a keel that goes down inside the shin bone. This right here is one of the ligaments on the inside part of the knee that helps maintain stability of the knee after the replacement. There's an opposing ligament on the other side of the knee, not shown on the diagram. And this right here in the front is what's called the extensor mechanism with the patellar tendon, the kneecap where patella lives inside that tendon, and then you have the quadriceps tendon leading up to the quadriceps muscle up the thigh. On the right-hand side of the screen, you can see the x-ray of a knee replacement. This right here is the metal cap that is glued to the end of the thigh bone. Here is the metal cap on the top of the shin bone, which is this piece right here. And it's got this part called the keel that goes down into the shin bone. In between those two, this gap right here is this piece of plastic, which is the new bearing of the knee joint, and replaces the cartilage that the patient had worn out. That is a standard appearing knee replacement x-ray from the front view, also called an AP view, and certainly what we hope to achieve with a knee replacement for most patients. Many people think that arthritis is something that grows in the knee, whereas actually the opposite. Arthritis is a loss of cartilage padding between the bones of the joint. And so arthritis is a loss of material, not a growth. Therefore, once we cut it out, it cannot come back. Knee replacement is not a perfect operation. What I mean by that is that I cannot turn the clock back and make you 20 years old again. Patients that have arthritis have a damaged knee with that arthritis, and we cut that out and replace it with metal and plastic, but that is not a perfect recreation of the knee you were born with. A metal and plastic knee replacement will always feel a little bit differently and function a little bit differently than a normal knee. Most people do not forget that they've had a knee replacement. Knee replacements are able to decrease your pain, improve your function, improve your quality of life, and give you back the freedom of mobility that you were missing. It can typically get people back to 80 to 90% of the normal knee function they had when they were young, but we cannot achieve perfection. I like to tell my patients that a knee replacement is an improvement, not perfection. We do expect you to get better, but notice that I did not say that patients will have no pain after a knee replacement. This is once again improvement, not perfection. And so we are hoping to get you better, but not perfect. Notice that I did not say that patients have no pain after knee replacement. Knee replacement is good at decreasing pain, but not necessarily completely eliminating all pain. Knee replacement is an improvement, just not perfection. We hope for a perfection, though we can reasonably achieve improvement in your pain, function, and quality of life. One unusual thing about knee replacements is that they all click. What's happening there is that as you move throughout the day, the metal and plastic will touch each other and may make a click in the knee. Every knee replacement does this. Your family and friends should not hear you clicking. You may feel the clicking or may hear it, though no one else around you should hear it. Getting down on your knee to kneel or crawl after a knee replacement can be uncomfortable for patients after the surgery. I will give you a protocol you can work on after the surgery to build tolerance to putting that pressure on the front of your knee, though many patients don't find it comfortable even after going through the protocol. From a satisfaction standpoint, 85 to 90% of people are happy with their knee replacements, but it's unusual to have chronic pain after your knee replacement. 4 out of 10 people, or 40%, can occasionally have pain after their knee replacement. And the reason for that is because I'm not replacing your whole leg. You still have all the muscles, the tendons, the ligaments, and the bone around the knee replacement that help your leg function. If you step in a hole in your yard and sprain your knee because you stress the ligaments and tendons, you may still have some knee pain. If you decide to take up a new sport and aren't used to playing sports, you might have some muscular pain. But typically it's not the knee replacement that hurts itself, it's the supporting structures around it. Having chronic, unrelenting pain after a knee replacement is thankfully rare, and if you have that, it will necessitate a workup as to try and figure out why you're having that and to treat it. Surgery is not risk-free. I'm about to give you some risks of the surgery and tell you some general percentages of what you can expect from a risk standpoint when you have your knee replacement. These general percentages are based on the scientific literature, but each individual patient's individual circumstances and medical comorbidities may alter these numbers. In general, infection risk with a knee replacement is about 1% over the course of your entire life. Your risk of infection never completely goes away to zero. There is a theoretical risk that I could injure a blood vessel or a nerve in your knee. That is very unlikely to happen, and that has never occurred to me in my practice. One thing that patients will get with an incision down the front of their knee is a numb spot on the outside, or what we call the lateral part of the incision. That numbness tends to be permanent. Bleeding to the point of needing a blood transfusion is very rare, much less than 1%. There's also a less than 1% risk that I could break a bone or ligament in your knee. If I do that, I will fix it. I will not call your family and ask permission, but I will tell you about it after the surgery. Recovering motion after knee replacement is one of the main goals of physical therapy. Recovering the ability to fully straighten or extend the leg, as well as bend the knee as far as we want you to. The chance that you would get stiff and not achieve the motion we are looking for and need surgery to break up that stiffness is about 1%. The surgery that is used to break up stiffness is called a manipulation under anesthesia. While speaking about motion, the average motion after a knee replacement is from fully straight, what we call 0 degrees, to bending to about 115 degrees. Most people cannot get their heel to their butt after a knee replacement. The best predictor of your motion after your knee replacement is your motion before the knee replacement. So if you have stiffness before your knee replacement, you should do physical therapy prior to the surgery to make your motion as good as it can be, because that's going to predict what your motion is after the knee replacement. Knee replacement is not a motion improving surgery. It is a pain relieving surgery. Blood clot risk is generally 0.5%. We will ask you to take a blood thinner for about 6 weeks after the surgery to help prevent blood clots. Typically that is baby aspirin twice a day for those 6 weeks. If you are already on a blood thinner, that will likely be the agent we use to help prevent blood clots in you. From a longevity standpoint, the primary determinant of how long your knee replacement lasts is at what age you had the knee replacement done. For people over 65, they can expect the knee replacement to last longer than 30 years. There is an approximately 30% failure rate at 30 years for people over 65 when they have a knee replacement. For those people, this should last them the rest of their life. For people under 50, they will not last the rest of that patient's life if they live a normal lifespan. For people under 50, they can typically expect a 10 to 15 year survivorship out of their knee replacement. And for people between 50 and 65, they can expect somewhere between 15 and 30 years out of their knee replacement. Once again, these are all generalizations, and every individual patient and their circumstance will alter these numbers. Here at Carilion, we do knee replacements at 2 different hospitals. One is at Roanoke Memorial Hospital, and the other is at Community Hospital. Depending on what day of the week you have in your health, you may have surgery at one location over the other. The morning of the surgery, you will come to the hospital. We do the operation, which typically takes about an hour and a half. Some more complicated surgeries may have a longer surgical time. You then go to the recovery room, which typically is a 1.5 hour stay in the recovery room, and then you go to a hospital room for therapy. The total time from when you leave the pre-op area until you go to a hospital room is typically about 3 hours, and that is a fairly rough average. But that is the time that your family will have to wait while you are in the operating room and also the recovery room. Once you go to a hospital room for therapy, the nursing staff will let your family know what hospital room you're heading to, and then your family can be with you. Once you're in the hospital room, we will work on all the goals we have for patients after knee replacement. You will work with a physical therapist and be up walking on your surgical leg the day of the surgery. The therapist will show you how to use a walker to help you walk. They will also show you exercises to do to help you recover from your knee replacement, and they will have you go up and down stairs if you need to do that to get around your house. The other goals we have for you to have your pain controlled on oral medications, be able to avoid and go to the bathroom, be able to drink water and eat food and tolerate that without nausea, and be able to pass physical therapy. Once you have completed all those goals and are safe, we will get you home. We do not send patients to nursing homes or rehab hospitals after these operations, as those facilities are not medically safe for patients to heal at. You are much safer medically at home. I do need you to have 24-hour care for the first 7 days after the surgery at home though, which means that you will need someone to come and stay with you, or you go stay at their house for the first 7 days after the surgery and have someone with you all the time for those first 7 days. Your insurance will not pay for someone to come and do that. We rely on family and friends in order to provide that care. Currently, about 80% of people go home the day of the surgery, which means that the other 20% of people typically stay in the hospital just overnight and then usually go home the next day. But this is not a choice. Once you are safe and have met all of our goals, we get you home. Once you are home, we will set you up with home health physical therapy, typically for the first 2 weeks after the surgery. The therapist will come to your house and work with you on walking, going up and down stairs, getting off the walker to a cane, getting in and out of your car, all those goals. After those 2 weeks of therapy at home, we will typically transition you to outpatient physical therapy, where you will go to an office near your house and do more physical therapy. You get to choose what therapy office you go to. Typically, between the home therapy and the outpatient therapy, patients will do between 2 to 3 months of therapy on average. So we are talking about quite a bit of therapy to recover from your knee replacement. From a driving standpoint, we don't recommend that patients drive at least for a little bit after the surgery, but there are no specific driving restrictions like you may have heard of in the past. In order to go back to driving, you need to have 3 things be true. First, you cannot be in a brace or have any weight-bearing restrictions. This would be abnormal for people after knee replacements. Second, you need to be off any of the narcotic pain medications that most people take for pain after the surgery. And third, you need to feel safe to drive. My team and I will not clear you to drive. You and your family can decide when you are ready once you meet those 3 goals. From a recovery standpoint, most people can expect a 3-month recovery after their knee replacement. And what I mean by recovery is that by 3 months, the muscles and tendons have healed back from the surgery. Most people who work have returned to work by 3 months. Most people could take and enjoy a vacation, go shopping for the day, or push mow a yard. Those first 3 months are actually 80% of the full recovery. But full recovery, as good as your leg can get after a knee replacement, takes 1 year. Let me restate that. Full recovery after knee replacement takes 1 year. The first 3 months of that are 80% of the recovery, so the majority. The next 9 months after that is about building back the strength and stamina in the leg, and that is the last 20% of the recovery. Returning to work after surgery is very individualized. There are no hard and fast rules about when to return to work, but I can give you some general guidelines. For people who work from home, they typically will take about 2 weeks off of work. For people who work in an office, they can typically expect to get back to work within 4 to 6 weeks, though they will still need to be able to prop up their leg and ice it throughout the day. For people who do heavier labor or work in factories or construction, they would typically take between 8 and 12 weeks off of work. Many companies offer Family Medical Leave Act time, called FMLA, that allow patients to take time off and recover from surgery. The maximum allowed time federally is 12 weeks. If you bring me FMLA paperwork to be filled out, I will fill that out to give you 12 weeks off work because that is the 3 months of the average recovery. And by then, most people have returned to work. If you go back to work sooner than 3 months, great. If you need the 3 months to recover, that is fine. I wanted to thank you for taking the time to watch my surgical discussion video. This video contains the information that I think is important for patients to know before they undergo a hip or knee replacement. That being said, you may still have questions that I did not cover in the video. Just to reiterate, there are 3 options for how we proceed prior to your surgery after you watch this video. The first option would be that all of the information that we have given you, including this video, has answered all your questions, and you do not need an appointment with me in the office. If that is the case, then you will just have your pre-surgical appointments and will not need to see me until the day of the surgery. The second option is that you may still have some questions after reading the materials and watching this video. In that circumstance, you could schedule a telemedicine visit with me in order to go over your questions over the phone. I'm happy to answer your questions over the phone in this circumstance, though you may have a small co-payment with your insurance for that telemedicine visit. The last option would be that you still have questions that you would like to have answered after reading the materials and watching this video, and you do not think that they'd be amenable to discussing over the phone. In that circumstance, I'm happy to see you back in the office prior to your surgery with an in-person visit, and we can go through your questions. Just like with a telemedicine visit, you may have a co-payment for this visit, but I'm happy to sit down and answer your questions prior to your surgery. If you do wish to schedule either a telemedicine or an in-person visit, you can either contact my staff through my chart or by calling the office number, and we will get you set up with an appointment prior to your surgery with me to answer your questions. I would like to thank you for trusting me to be your surgeon for your upcoming joint replacement surgery, and please know that my team and I will do our best to care for you as if you were a member of our family.